This is Akram Jafar, and today I'm going to deal with the peripheral nervous system with a focus on spinal nerves and the innervation of the limbs. Let me remind you about the structural divisions of the nervous system. The nervous system is first divided into a central nervous system, which consists of the brain and spinal cord, which we are not going to deal with today, and the peripheral nervous system, our interest today, but our main focus today is on spinal nerves. So what are the spinal nerves? As their name indicates, they are branches of the spinal cord. That's why they are called spinal nerves. We have 31 pairs of spinal nerves. The naming of the spinal nerve, to start with, it conforms with the naming of the regions of the vertebral column in which the spinal cord is located. So we have cervical region, we have thoracic region, and so we have thoracic spinal nerves, we have a lumbar region, lumbar spinal nerves, and sacral region, sacral spinal nerves, and a coccygeal spinal nerve. In most of the regions, the number of spinal nerves conforms to the number of vertebrae. So we have 12 thoracic vertebrae and 12 thoracic spinal nerves. We have 5 lumbar vertebrae and we have 5 lumbar spinal nerves. We have 5 sacral spinal nerves, although we have a single bone, which is the sacrum, but originally it was made of 5 vertebral segments that fused together, and we have 1 coccygeal nerve. The only exception here is that in the cervical region, we have 8 cervical nerves, yet we have 7 cervical vertebrae. So what are the implications of this? In the cervical region, you can see here that the spinal nerve arises above the numerically corresponding vertebra. So the the C1 spinal nerve arises above the atlas vertebra, which is the first cervical vertebra, C2 nerve above C2 vertebra, and so on until we reach C8 nerve. Because we have only 7 cervical vertebrae, then C8 nerve will arise through the intervertebral foramen that is located between C7 vertebra and T1 vertebra. And from that point downward, all the spinal nerves will be related below the numerically corresponding vertebra. So you can see here, T1 spinal nerve is below T1 vertebra, T2 below T2 vertebra, let's say L4 spinal nerve below the 4th lumbar vertebra, and so on. Knowing about this will help us localize the site of the lesion, like radicular lesions that affect the roots of the spinal nerve. For example, herniation of intervertebral discs. In the cervical region, the herniation commonly occurs between C5 and C6 vertebra. So this means that C6 nerve will be compressed and affected. Herniation between C6 and C7 vertebra means that it is the C7 nerve that is going to be affected, because we know how the nerves are related to the numerically corresponding vertebrae. Now, how does this spinal nerve or each of these spinal nerves are formed? Each spinal nerve is connected to a segment of the spinal cord, and it arises by roots. It's like a tree. The tree has roots. They begin as rootlets, and the rootlets, they span the thickness of the spinal segment, and then they unite to form 2 roots. There is a ventral root, as you can see here, or anterior root. We can use these terms interchangeably. And there is a dorsal root or a posterior root. Again, it can be used, the 2 terms can be used interchangeably. So functionally speaking, the anterior root contains efferent or motor fibers. These fibers, they have their cell bodies of the neuron located in the anterior horn of the spinal cord and the gray matter. The dorsal horn, it contains efferent fibers, the fibers that are sensory fibers. The cell bodies are located in a dorsal root ganglion. So a ganglion, by definition, is a collection of nerve cell bodies outside the central nervous system. And here, these ganglia, actually, there's no synapse. They contain only nerve cell bodies. And the nerve cell body is of special type of nerve. It's called pseudo-unipolar. That's to say it has one process that immediately divides into a central and peripheral process. And then these 2 roots, as they join together, they will form the spinal nerve. Therefore, the spinal nerve contains two types of fibers, sensory and motor fibers, but the roots, they either contain sensory or motor fibers. It's not a mixture like the nerve itself. So the roots are located in the vertebral canal, and then they, as I said, they unite to form a spinal nerve, and the spinal nerve will arise from an intervertebral foramen between two vertebrae. Now you know the relation of the spinal nerve to the vertebrae. Usually the spinal nerve arises below the numerically corresponding vertebra, except in the cervical region where they arise above the numerically corresponding vertebra, except the C8 as we have just mentioned. And then the nerve, which is a mixed nerve, as it arises from the intervertebral foramen, it will soon divide into, as you can see here, a ventral ramus and a dorsal ramus. So a ramus means branch, like a stem in a branching tree divides into a ventral branch, ventral ramus, and a dorsal ramus. Because the stem contains two types of fibers, sensory and motor, then each of these branches, they contain sensory and motor fibers. You can see here that the ventral ramus is usually bigger than the dorsal ramus. I will tell you why. You can see here in this section, it's a cross section in the thorax showing one of the thoracic spinal nerves. You can see that it has a dorsal ramus that has motor branches supplying the muscles of the back, the erector spinae muscle, and sensory branch that supplies the skin overlying the back, actually the central region of the back on either side of the midline. So it's a small mass of muscle, small area of skin. That's why the dorsal ramus is smaller than the ventral ramus, while the ventral ramus, if we follow it, it will go around the trunk, supplying the muscles of the trunk. In this case, they are the intercostal muscles and the thorax, or below that, they will supply the muscles in the abdomen, and it sends a lateral cutaneous branch supplying the lateral side of the body, and an anterior cutaneous branch supplying the anterior part of the trunk. So you can see that both rami, they are mixed sensory and motor. Now in the trunk, you can see that there is uniform supply of the muscles and the skin, like segments of the trunk, unlike in the limbs, as I'm going to mention in a moment. Here, the anterior ramus of the spinal nerve, or the ventral ramus, has a special name. It's called an intercostal nerve because it is located between two ribs. So the first 11 thoracic spinal nerves, their anterior rami, they form the intercostal nerves. Why I said the first 11 thoracic spinal nerves? Because T12 thoracic spinal nerve, its ventral ramus, is not located between two ribs. It is located, in fact, below the 12th rib, so it is called the subcostal nerve. Also, we should keep in mind that the T1 spinal nerve, its ventral ramus, does not reach the thoracic wall. You can see here, thoracic wall is supplied from T2 downwards, because most of the ventral ramus will go to join the lower cervical nerves and form a plexus of nerves, as I'm going to talk about, that supply the upper limb. So it doesn't supply the skin of the thoracic wall, but on the other hand, it supplies the skin on the medial side of the arm. T2 reaches the thoracic wall, but in addition to that, it supplies a small area. In fact, its lateral cutaneous branch, this one, supplies a small area of skin of the axilla and the upper part of the arm. That's why the lateral cutaneous branch of the second intercostal nerve is called the intercosto-brachial nerve, because it supplies intercostal spaces and muscles and skin, and at the same time brachium, because it supplies part of the skin of the arm. The first 6 intercostal nerves, they are confined to the thorax and the muscles and skin, but below that, from 7 to 12, they supply the skin and muscles and the abdomen. You can see how the skin is supplied here in the form of segments in this case, and this will take us to the topic of dermatomes. So the dermatome, by definition, derma, skin, tome is a piece, so it's a piece of skin that is supplied by a single spinal nerve. They are, as you can see here, they are uniform in the trunk, and not only uniform, but they are overlapping. So that's why you can see here, for example, the dermatome of T5 spinal nerve is overlapped by the dermatome of T4 and T6 spinal nerve. So this has a clinical implication. If there is an injury to T5 spinal nerve, then there will be no loss of skin sensation. The reason is that the area of skin supplied by T5 is overlapped by the neighboring T4 and T6. Also, we can see here that the dermatome of C4 is the skin covering the clavicle and the shoulder, tip of the shoulder. And then immediately after C4, we have T2. As I mentioned, that T1 doesn't reach the skin of the thorax. It supplies the skin here in the arm and forearm, but it doesn't reach the thorax. And so you can see here that the dermatomes at this level, which is the level of the sternal angle, the angle of Louis, which is the manoperisternal joint, level of the second costal cartilage. At this point, the dermatomes jump from C4 to T2. The remaining dermatomes, as we will see later, C5, C6, C7, C8, and T1, they are borrowed to the upper limb because they form the brachial plexus. Of course, you're not supposed to memorize all the dermatome maps in the body, but there are some dermatomes that are useful if you keep them in mind. For example, the dermatome at the level of the nipple is usually the T4, T5 dermatome. The dermatome of T7 is located in the subcostal angle or the epigastric region. T10 is at the level of the umbilicus. L1 is in the suprapubic region and the groin. You can see here clinical example of how dermatomes are delineated on the surface of the body, and in this case in a disease called herpes zoster or shingles, which affects the dorsal root ganglia. So the vesicles are going to be distributed along the area of skin that is supplied by that nerve. And you can see here, this area is delineating the dermatome of T5. And then this area, which is above at the level of the top of the shoulder and the overlying the clavicle, down to the level of the manoperisternal joint, indicating that it is affecting the C4 spinal nerve. Here you can see the dermatome maps. Sometimes they are conflicting. This is one of the old dermatome maps. Again, you can see here how the dermatomes, they are sequentially arranged in the trunk, but in the recent dermatome, like this one, which is a composite dermatome using data from multiple publications, you can see that the dermatomes, they will lose this sequential arrangement as shown in the trunk. This will be lost in the limbs, where there will be some spiraling of the dermatomes in the lower limb. In the upper limb, you can see that the dermatomes are arranged downwards from the lateral side of the upper limb, then upward on the medial side. This arrangement is related to the embryological origin, because embryologically speaking, the limbs, they bud from the body, and you can see here that each limb, the thumb side or the big toe side, is toward the head. And of course, you can see here that as the limb is budding, it is dragging with it the nerves and the dermatomes. And then after that, there will be rotation. But the rotation is a reverse rotation. In the upper limb, the rotation takes place in a lateral direction, lateral rotation, while in the lower limb, there will be a medial rotation. That's why in the anatomical position, the thumb is located on the lateral side of the body, while the big toe is located on the medial side of the body. Although at the beginning, both of them, they were in the same direction, which is the direction of the head. So you can see here in the upper limb dermatomes, they are supplied by branches from C5 to T1. There is a very small area that is supplied by T2, the intercostobrachial nerve. But from C5 to T1, the nerves will form a plexus, which is called the brachial plexus. And you can see that the numerical sequence, when traced distally down the lateral side, as I said, and then proximally up the medial side of the arm. The middle fingers here is the area of C7. The thumb is the skin over the thumb, I mean, is the area of C6, while the little finger is the area of C8. And then remember T1 here, that supplies the medial side of the forearm, and the arm doesn't supply the skin in the thoracic region. In the lower limb, as I said, there is some sort of spiral arrangement. So there's on the anterior side, there's L1, L2, L3, and then L4 is on the medial side. So L4 is on the medial side of the leg, and the L4 dermatome supplying the skin over the big toe. And then we have L5 supplying the middle toes and then the lateral side of the leg. And S1, S for small, supplying the little toe. And then also it is supplying the skin overlying the heel. S2 extending on the back of the leg and back of the thigh until it reaches S3 and S4. It is the skin that we sit on. Now in the limbs are supplied by plexuses, unlike the trunk. You can see here the nerves that supply the trunk, they pass on their own. They do not form a plexus. A plexus means a network. So here, these networks that supply the limbs, let's take an example here, the brachial plexus that supplies the upper limb. It is formed by the union of the anterior rami of spinal nerves, C5, C6, C7, C8, and T1. You can see here that the fibers, there is an exchange of fibers, and then the fibers will unite to form the peripheral nerves, branches of the plexus. So for example, the median nerve, one of the major branches of this brachial plexus, this nerve is not formed by a single anterior ramus of a spinal nerve. Fibers from C5, fibers from C6, C7, C8, and T1 can be present in the median nerve. Another example here, the musculocutaneous nerve is formed from, let's say, C5 and C6 fibers. So as you can see here, that in a plexus, any one spinal nerve can contribute to more than one peripheral nerve, which is a branch of the plexus. This is true for the brachial plexus, true for the lumbosacral plexus, which is involved in the nerve supply of the lower limb. And so the peripheral nerves, they can receive fibers from more than one spinal nerve. It's unlike an intercostal nerve, let's say, in the trunk, only has fibers from one spinal nerve. Now, this fact would be reflected on the area of skin that is supplied by the nerve roots, which is the dermatome, and the area that is supplied by the branch of the plexus. Returning back to the dermatomes, this is the area of skin supplied by C4, this is the area of skin supplied by C5, and this one is supplied by C6. As I said, they go down on the lateral side of the arm and then up on the medial side of the arm. But these skin areas of the dermatome, they do not conform with the branches, the cutaneous branches of the axillary nerve, which is one of the major branches of the brachial plexus, or the radial nerve, or the lateral cutaneous nerve of the forearm, and so on. Knowledge about these areas and the loss of sensation in the skin will help us in diagnosing whether this is a radicular neuropathy or it is a peripheral neuropathy. If it conforms with the dermatome map, then it is a radicular neuropathy. If it conforms with the peripheral nerve map, it conforms with a peripheral neuropathy. Now, in addition to dermatomes, we need also to have an idea about myotomes. A myotome, as the name indicates, is a group of muscles that are innervated by a single spinal nerve, usually muscles sharing a common primary function on a joint are supplied by the same spinal cord segment, usually two adjacent segments of spinal cord. For example, here, the myotome, the muscles that are responsible for flexing the hip, are supplied usually from L1 and L2. The muscles that are responsible for extending the knee are supplied from L3 and L4. Muscles responsible for dorsiflexion at the ankle L4 and L5, while plantar flexion S1 and S2. You can see here that usually the opponent, roughly, the opponents of the movement, they are supplied by segments that run in a numerical sequence with the former. So dorsiflexion here is L4, L5, plantar flexion is S1, S2. That's to say it is served by S1 and S2 spinal nerves that supply the bulk of muscles that are producing this movement, usually here the muscles of the calf. And so testing the movement at successive joints can give you an idea about localizing lesions to specific nerves or specific spinal cord segments. So while trying to localize the nerve injury, you can use the dermatomes, you can use the peripheral nerve maps, you can use the myotomes, and in addition to that, especially in an unconscious patient, you can use the tendon reflexes. One of the important tendon reflexes in the lower limbs are the knee jerk, which is tapping on the patellar tendon, will result in extension of the knee, and this is served by L3, L4 spinal cord segments. You can see here L3, L4, while tapping on the Achilles tendon behind the ankle, which is called the ankle reflex, you are testing S1 and S2 spinal cord segments, because this will result in plantar flexion of the ankle joint. Same thing is true for the upper limb regarding the segmental innervation of movements in the upper limb, the myotomes. The rule holds that the more distal joints are innervated from lower centers in the cords. So you can see here C5 and C6, mainly C6, is responsible for flexion of the elbow, while extension of the elbow is mainly served by C7. And flexion of the fingers, this movement here, is mainly C8. Movements of the fingers in this way, adduction and abduction of the fingers, moving away from the middle finger is an abduction, moving toward the middle finger is an adduction. Both these movements, they are served by T1. You will notice that the myotome of the intrinsic muscles of the hand is mainly served by T1. Remember that T1 spinal nerve is one of the components of the brachial plexus. T1 spinal nerve doesn't reach the skin of the thorax, but most of it is contributed to the brachial plexus, where it supplies the skin in the medial side of the arm and forearm, and it will be distributed with the branches of the brachial plexus, like especially here the ulnar nerve, to supply the intrinsic muscles of the hand that contribute to adduction and abduction of the fingers. Now let's have an example here, a case. A 45-year-old man presented with pain, tingling, and numbness on the medial side of the forearm and hand when holding a heavy suitcase. But when the suitcase is dropped, recovery occurs in few minutes. Physical examination revealed wasting of the small muscles. You can see here the small muscles, which are the muscles located between the metacarpal bones. They have been wasted, because this means that the nerve injury is a chronic one. It's not because wasting of a muscle results from disuse of a muscle. So there will be wasting of the muscle, as well as weakness of finger adduction and abduction. Radiological examination confirms the presence of a cervical rib. Which of the following nerve roots was most likely affected? So from our previous knowledge, we know that the myotome of the small muscles or intrinsic muscles of the hand is the myotome of T1. And also we know that T1 not only supplies muscles, but it also supplies the skin. The skin of the medial side of the forearm is supplied by T1. You can see here that T1 as well as C8 supplies skin, and in this case it is supplying the skin on the medial side of the forearm. The hand actually is innervated mainly by, the skin is innervated by C8, but mainly here T1 is affected more than C8, and this actually is related to the pathophysiology of this condition, the condition of a cervical rib. So here you can see that T1 is so close to the upper surface of the first rib here, and a cervical rib means that there is an extra rib that is connected to C7 vertebra. You can see it here. This is the extra rib in green, and this will result in kinking of the T1. The kinking mainly affects T1. C8 might also be affected, but it will mainly affect T1 because T1 nerve has to go higher up and down, and so it will be kinked, and this will result in the neuropathy. And this will be accentuated mainly when the person holds something heavy in his hand, because otherwise the cervical rib might pass unnoticed. It might be symptomless. Okay, so the correct answer here is T1. Now, in the upper limb, again, tendon reflexes. There are two tendon reflexes that are tested usually. The biceps reflex is mainly testing C6. Remember here, the relation C6 will be affected if there is an herniation of the intervertebral disc between C5 and C6. Remember the relation of the spinal nerve to the numerically corresponding vertebra. And the other reflex that is tested is triceps reflex, which mainly tests actually C7. Tap on the triceps tendon behind the elbow, and this will result in extension of the forearm. In the lower limb, the innervation is provided by two main plexuses, the lumbar plexus from L1 to L4, anterior rami of these spinal nerves, and the sacral plexus from L4 to S5. You can see that L4 contributes to both of these plexuses, and both of these plexuses, they are involved in the innervation of the lower limb. Sometimes they are referred to as the lumbosacral plexus. So the nerves from L1 to S5, this means that they are tested clinically in the lower limb. They are not tested on the trunk. They are tested clinically in the lower limb to diagnose injuries and locate disorders, especially those related to herniation of intervertebral disc that mainly affects the lumbar region, lower lumbar region, either between L4, L5, or between L5 and S1. These are the two main sites where a herniation of intervertebral disc might occur because of the highest body weight will be applied to these intervertebral discs. I would like to remind you before that the spinal cord does not extend the entire length of the vertebral column. It extends down to the lower border of L1 vertebra. Below that, we do not have a spinal cord. We only have the rootlets of the spinal nerves that will form a tuft of nerves, which is called the coda equina. So when we are talking about the levels of L4, L5, or L5S1, the herniation of intervertebral disc will not affect the spinal cord, but will affect rootlets of spinal nerves that form the coda equina. And because of the thickness of the lumbar vertebrae, then the herniation, let's take an example here, the L4, L5 intervertebral disc. You can see here that the L4 roots, which is present between L4 and L5, we said that below the cervical region, the spinal nerve leaves the intervertebral foramen below the numerically corresponding vertebra. So between L4 and L5 vertebra, it is L4 that is leaving. But because of its lateral position, it will escape the pressure from a herniating disc in this region. Keep in mind that usually the discs, they herniate not exactly in the midline, but of the midline. So in this case, the herniation of a disc between L4 and L5 will compress the rootlets of L5 spinal nerve, not L4 spinal nerve. Although L4 leaves between L4 and L5 vertebrae, but it will escape the region of herniation because of its higher and lateral position. And so the herniation usually affects the rootlets of the next spinal nerve. But in the same way, herniation between L5 and S1 will not affect L5, but will affect the S1 nerve roots. And so if L5 is affected, remember the myotomes, then we will have a problem in dorsiflexion. If S1 is affected, we have a problem in plantar flexion. If you go back, remember here, So this is L5 dorsiflexion, and S1 is plantar flexion. And also remember the dermatomes. So L5 here is in the dorsum of the foot and the lateral side of the leg, while S1 affecting the or supplying, let's say, the skin of the little toe and the skin over the heel. So let's take another case here. A 30-year-old man was struggling to move a washing machine when he suddenly felt pain in the lower back, which extended down his left leg. This is a typical example of sciatica. Physical examination and MRI study confirmed the presence of herniation in the disc between L5 and the sacrum. So which of the following findings was detected during physical examination? A disc between L5 and sacrum, herniation of such a disc is this one, L5 and the sacrum, will affect S1 roots. It will not affect L5 because L5 escapes. It's higher up and more lateral than S1. So this means that S1 is affected. And so we will try to find what is the motor function that is served by S1. Diminished knee jerk, we know well that the knee jerk is served by L3, L4. So it's far away. Diminished ankle jerk, well, there is a possibility here. The ankle jerk here is served by S1, S2. So yes, it will be affected. Testing the ankle jerk will be much diminished. Let's find other options here. Sensation over the medial toes. The medial toes are served by L4. It will affect, S1 is affected, so it should affect the little toe and the heel, but not L4, not the big toe or the medial toes. Diminished sensation over the lateral leg. Lateral leg is L5. You can see that here. Lateral leg is L5, not S1. S1 is the little toe and the heel. So this is again wrong. Wasting of the front of the thigh. Actually, the front of the thigh is served by the lumbar plexus, not by the sacral plexus. L3, L4 spinal nerves. So this is again wrong. And the correct answer is that the patient will have a diminished ankle jerk. Now, regarding the motor innervation in the lower limb, as I said, it is served by the lumbosacral plexus. So the branches of this plexus, in this review, I'm not going to go into details, but I'm just going to give some general principles. So branches of the sacral plexus, we have a superior gluteal and inferior gluteal nerves. The superior gluteal nerves supply mainly these two muscles, the gluteus medius and gluteus minimus, and the inferior gluteal nerve supplies the big muscle, the gluteus maximus muscle, which is responsible for powerful extension at the hip. And also you can see here the biggest nerve of the sacral plexus, which is called the sciatic nerve. It's the biggest nerve of the plexus, biggest nerve in the body. This nerve, as it reaches the popliteal fossa, the diamond-shaped fossa behind the knee joint, will divide into two components. One of them is called the common fibular or common peroneal nerve, and the other one is called the tibial nerve. And the sciatic nerve itself supplies the hamstring muscles on the back of the thigh, the muscles that extend the hip and flex the knee. And then we have the contribution from the lumbar plexus. So the lumbar plexus, main branches of the lumbar plexus include the femoral nerve and the obturator nerve. If we look at a section here of the thigh, this is the level of the section, middle of the thigh, you'll see the femur here, and this is a group of muscles on the front of the thigh, which is supplied by the femoral nerve. These are knee extensors, in fact. And then on the posterior, we have this group of muscles, which is called the hamstring compartment. These muscles that are supplied by the sciatic nerve from the sacral plexus. They are knee flexors, hip extensors. And on the medial side, the muscle group, which is located here, is called the adductor muscles. And they adduct the hip, and they are supplied by the obturator nerve. Obturator nerve is another branch of the lumbar plexus. So the lumbar plexus supplies the anterior muscular and medial muscular compartments, but the sacral plexus through sciatic nerve supplies the posterior compartment, the hamstring compartment. If we go down in the leg, you'll find that these are the two leg bones, tibia and the fibula, tibia on the medial side. And so you have an anterior compartment here, which is served by the deep fibular or deep peroneal nerve. Remember here that the sciatic nerve, as it reaches the popliteal fossa, divides into a common fibular component and a tibial component. It's called common fibular because eventually it's going to divide into deep and superficial branches. So the deep branch is supplying the muscles of the anterior compartment. These are mainly ankle extensors or dorsiflexors, we call them. They dorsiflex at the ankle joint, which is a movement of extension. And then the superficial one, the superficial peroneal, the superficial fibular, supplies the muscles here of the lateral compartment, and these are everters. Eversion means that when the sole of the foot faces laterally, so they are called the everters, while the posterior compartment here is supplied by the tibial nerve. The posterior compartment is a group of muscles that mainly cause ankle flexion, or what we call it plantar flexion, like in ballet dancers when they stand on the tiptoes. The sensory innervation in the lower limb, we have just seen the dermatomes. I will remind you about the dermatomes of the lower limb. So these are the dermatomes of the lower limb, and compare them with the maps of the peripheral nerves, which are the branches of the plexuses, while the sacral plexus and the lumbar plexus. So in the lumbar plexus, we have the femoral nerve supplying the front of the thigh, the medial side of the leg, and the medial side of the foot. We have the obturator nerve, which supplies the skin over the medial side of the thigh. We have the sciatic nerve, which through its common fibular and tibial branches, they supply the back of the leg, they supply the sole of the foot as well. One of the common peripheral nerve injuries in the lower limb is the injury of the common fibular nerve. Remember here that the sciatic nerve, as it reaches the popliteal fossa, it divides into the common fibular nerve, and this nerve is going to supply these anterior and lateral compartments, so it's going to wind around the lateral bone of the foot, which is the fibula. So here you can see the common fibular nerve winding around the neck of the fibula. At this position, it has a superficial position, and not only it has a superficial position, but it is very close to the neck of the fibula, so that's why it can be easily compressed. So what will happen here? First of all, there are motor changes because the nerve, through its deep branch, it supplies the muscles of the anterior compartment of the leg, the muscles that dorsiflex at the ankle joint. So this results in weakness and paralysis of these muscles, resulting in foot drop. The foot drops as the patient walks, and there will be a loss in the ability of eversion because the superficial part of the nerve supplies the muscles which cause eversion. So these two motor functions will be weak or will be lost, and also there will be sensory loss on the lateral leg and the dorsum of the foot. Now let's deal with innervation of the upper limb. As I said, the upper limb is served by the brachial plexus, which is formed by anterior rami of C5, 6, 7, 8, and T1 spinal nerves. They are formed in the neck. It has roots, it has trunks, it has divisions. All of these are located in the neck and behind the clavicle. And when the plexus reaches the axilla, it will be divided into cords. So we have a lateral cord, a posterior cord, and a medial cord of the brachial plexus, and each one of these cords will have branches. We are here mainly concerned with the major branches of the plexus. So we have the musculocutaneous nerve from the lateral cord of the brachial plexus. We have the axillary nerve and the radial nerve from the posterior cord of the brachial plexus, and we have the ulnar nerve from the medial cord of the brachial plexus. And as you can see here, that from the medial cord and from the lateral cord, branches come together and form the median nerve, another branch of the brachial plexus. These are the major branches. Doesn't mean that they are the only branches, but they are the major branches of the brachial plexus: musculocutaneous, axillary, median, radial, and ulnar nerves. You can see that each one of these nerves is formed of axons that are contributed by multiple spinal nerves. So it's not only a single spinal nerve.
These are peripheral branches.
So if you take a section here in the arm, you will see that there are two muscle compartments: anterior flexor and posterior extensor. The anterior compartment is served by the musculocutaneous nerve. The posterior compartment is served by the radial nerve. In fact, the radial nerve in the upper limb is the nerve that supplies the extensor compartments, whether in the arm or in the forearm. If we go to the forearm here, this is the section. You can see that again there is a flexor compartment, the anterior compartment of the forearm, which is mainly served by the median nerve, except for 1.5 muscles, which are supplied by the ulnar nerve. And then we have the posterior compartment of the forearm, which as the extensor compartment, as like the extensor compartment in the arm, it is served by the radial nerve. Here you can see the sensory innervation. This map is not a dermatome map. It is the map of the skin areas that are supplied by the branches of the plexus. I will focus mainly here on the cutaneous innervation of the hand. This is very important in trying to localize certain neuropathies. So as you can see here, that on the palm side, the lateral 2/3 of the palm and the lateral 3.5 digits, they are supplied by the median nerve, while the ulnar nerve supplies the medial third of the skin of the palm and 1.5 digits. This area of skin extends on the dorsum of the digits down to the nail beds. On the dorsum of the hand, you see here that there is no contribution of median nerve. The radial nerve here contributes to the skin over the lateral 2/3 of the hand, dorsum of the hand, and 3.5 digits, almost similar to the area that is served by the median nerve on the palmar side of the hand. As I said, the ulnar nerve supplies only 1.5 muscles in the forearm, but it is the nerve that supplies almost all, not all, but almost all of the intrinsic muscles of the hand. The remaining part of the intrinsic muscles of the hand, they are served by the median nerve. So the median nerve is mainly for the muscles of the forearm, not the sole innervation, but contributes to some of the muscles of the hand. The ulnar nerve is the main nerve that contributes to the innervation of the muscles of the hand, but not the main nerve that's supplying them. And it also has a small contribution to the muscles of the flexor compartment of the forearm. The radial nerve does not, by all means, supply any muscle in the hand, but it supplies the skin in the hand. One of the most common nerve injuries that affect the upper limb is the carpal tunnel syndrome. And here, this is a section in the carpal region, a cross section. You can see here the carpal bones, they form like a groove when they come together. And this groove is made as a tunnel by a very thick fascia here, which is called the flexor retinaculum. And beneath the flexor retinaculum passes the tendon of many of the flexor muscles, that long flexor muscles that are located in the anterior compartment of the forearm, making this tunnel a very tight tunnel. Unfortunately here, passing together with these tendons is the median nerve. The median nerve that mainly supplies the muscles in the forearm, but it supplies the skin in the hand, and it supplies some of the muscles in the hand, especially those that move the thumb and make the bulk of what we call the thenar eminence. So this nerve, unfortunately, passes through this compartment. The other nerves, the ulnar nerve, the radial nerve, the blood vessels, the ulnar artery, the radial artery, they escape this tunnel. So what does this mean? That when there is inflammation, especially of the synovial sheaths that surround these tendons, long flexor tendons, the tight compartment, because it is made of thick fibrous tissue, the flexor retinaculum and bones, cannot expand, and so this will result in pressure on the median nerve, what we call the carpal tunnel syndrome. The patient will suffer of pain and tingling in the skin area that is supplied by the median nerve. We have just mentioned that. The lateral two-thirds of the skin of the palm and the lateral 3.5 digits. And also there will be motor changes because some of the small muscles of the hand, especially those that are affecting the thenar eminence, these muscles will, first of all, they will atrophy, as you can see here. There will be flattening of the thenar eminence. And second, that the patient will not be able to use the thumb, especially in opposition, because the muscles like the opponens pollicis, the flexor pollicis brevis muscles, which serve the opposition, which is a very important movement here in the hand for the pincer-like action of the hand, will be affected. On the other hand, there is one muscle here, which is deep muscle. It's called the adductor pollicis, which causes adduction of the thumb. This muscle is not affected. It is still functional because it will be supplied by the ulnar nerve, not by the median nerve. So the patient will have difficulty in making fine manual tasks, like, for example, buttoning. But at the same time, because of the flattening of the thenar eminence and adduction of the thumb by the at least tone of the adductor pollicis served by the ulnar nerve, results in this sign, what we call the ape-like hand. This is to give you an idea about how the nerves, which are branches of the brachial plexus, peripheral nerves, are most likely affected by injuries. We have here, because of the close relationship of the axillary nerve to the neck of the humerus, then fractures of the neck of the humerus. Actually, this part of the neck is called the surgical neck of the humerus, might result in injury of the axillary nerve. And because the axillary nerve supplies mainly the deltoid muscle, which is responsible for abduction of the shoulder mainly, this will result in weakness and abduction of the shoulder. Then we have the radial nerve. The radial nerve comes from the axilla, passes behind the mid shaft of the humerus in a groove called the spiral groove or radial groove, because the nerve spirals from the medial side to the lateral side. So it will be affected in fractures of the midshaft, and this will affect the muscles, especially the muscles in the extensor compartments. In this region, particularly affected are the muscles of the extensor compartment of the forearm. Of course, the skin area that is supplied by the radial nerves. Remember, especially that is, we have just mentioned in the dorsum of the hand. The ulnar nerve will be affected by a fracture of the medial epicondyle of the humerus because of its close relationship to the medial epicondyle of the humerus. It passes behind the medial epicondyle of the humerus. In fact, you can roll it, and this will result in tingling and funny sensation. Probably this is a pun that is used for the humerus as the funny bone. So let's have this last case. A 40-year-old lady presented with wrist drop. She cannot extend her wrists, so the wrist drops by gravity, a condition that might remind you of foot drop, which we have just mentioned when there is an injury of the common fibular nerve. So this lady, she had a wrist drop. As in addition to that, there is loss of sensation over the dorsum of the hand. It's not mentioned which area, whether it is the medial area that is supplied by the ulnar nerve or the lateral area which is supplied by the radial nerve, but there is loss of sensation. In addition to that, the wrist drop. The question is asking about which of the following nerves is affected. So this wrist drop means that the muscles here in the extensor compartment of the forearm are not working. That's why they don't have a tone, and so the wrist drops by the action of gravity. These muscles, like the muscles of the extensor compartment of the arm, they are all supplied by the radial nerve. So we can conclude that the most likely injury here is resulting from radial nerve injury. Here the vignette is giving a hint actually of the cause of this nerve injury. She had a history of humeral shaft fracture 3 months ago. So remember here, humeral shaft, not the neck, not the medial epicondyle. It is the humeral shaft fracture where it might affect the radial nerve, but she had developed this condition 3 months later. because it is not necessarily that the nerve injury takes place at the time of injury, but because of the excessive callus formation. So the correct answer here would be the radial nerve. It is not the ulnar nerve, because the ulnar nerve is mainly concerned with the small muscles of the hand and with some 1.5 muscles in the flexor compartment. So it doesn't produce this condition. It might produce another condition, which is called the claw hand, but not the wrist drop. It is not the median nerve. The median nerve does not supply extensor compartment. The median nerve does not supply the dorsum of the hand. It only supplies the palmar skin, lateral 3.5 digits and lateral 2/3 of the palm. The musculocutaneous nerve, definitely, because the musculocutaneous nerve is mainly concerned with the flexor compartment of the arm, not the forearm. It is not the T1 roots. T1 roots would result in involvement of the small muscles of the hand and will affect adduction, abduction of the fingers, and might be affected in cases of a cervical rib, but not in cases of humeral shaft fracture in the arm. Thank you very much.